Welcome to the Stanford Women's Health Vodcast series. I'm Dr. Sharon Hung, Director of Women's Health for the Primary Care and Population Health Department at Stanford. From debunking myths to exploring the latest research, we will delve into the world of women's health with leading experts in the field. Today, I'm speaking with Dr. Deborah Sellmeyer. She's a board-certified endocrinologist and a professor of medicine at Stanford. She's an internationally recognized expert in metabolic bone disease and maintains a research program focusing on nutrition and environmental impacts on bone metabolism. Her work also involves studying osteoporosis medications and novel therapies for rare bone disorders. Dr. Sellmeyer is also recognized for her teaching and has received numerous awards. Dr. Sellmeyer, thank you so much for being here today.
Well, it's a pleasure to be here. Thank you for having me.
I wanted to start by asking you what motivated you to specialize in endocrinology and bone health?
Well, I think endocrine is a fascinating field because it allows us to look at the whole body. And instead of focusing on a single body part, we're very much looking at the relationship between different glands and effects on other glands. And I had the opportunity during my endocrine fellowship at UCSF, the bone and mineral research was exploding. And so it was just a really fortuitous time to be there and be able to participate in that research. And that kind of set me off on the path of metabolic bone disease, which I have loved.
Great. Well, we're so lucky to have you. I've learned so much from you over the last few years. So let's just jump right into screening. I think everyone remembers to screen women over 65, but can you remind us of indications in which we should be screening women at an earlier age?
We have the best data for women over age 65, and that is the most conservative screening recommendation, which comes from the U.S. Preventative Services Task Force. The challenge with men and with individuals under age 65 is we just lack the long-term data to show when screening can best help us reduce fracture risk. So other than postmenopausal women over the age of 65, there's a lot of clinical judgment that needs to come into play when deciding about whom to screen with bone density testing. So the main risk factors we think about are certainly people who've had fragility fractures, people who are on medications that compromise bone health, such as anti-epileptic medications or glucocorticoid treatment, and then folks whose demographics put them at higher risk. So smaller people, people with a family history of osteoporosis or hip fracture. So there actually could be quite a wide variety of people who would be eligible for sooner screening. And one of the really challenging areas, I think, for us in terms of screening is that early postmenopausal women are relatively low fracture risk, but they're also at a time of life where they're losing a tremendous amount of bone. And so personally, I kind of advocate for sooner screening and stopping that perimenopausal bone loss. You know, if we can stop that perimenopausal bone loss and keep that 10 or 12% decrease in bone density that everybody gets when they go through menopause, it just makes sense that that's going to reduce fracture risk long term, but we don't have the data to show that. So that has not really become part of our screening recommendations. But I think it's a real concern and an area that we need to really be thinking about in terms of long-term prevention of fractures.
I see. So it sounds like we're not screening all women earlier, mainly because of the limitations in the data we have so far, not so much that there's not benefit.
Not good reason to do so, correct.
Got it. And then I often come across a lot of other specialty guidelines on when they recommend screening for osteoporosis. For example, American Society of Metabolic Bariatric Surgery recommends starting DEXA screening 2 years after bypass surgery. American Gastroenterology Association also recommends considering starting screening for IBD patients after the age of 50 if they have certain risk factors. I just feel like there's so many guidelines to keep in mind. I'm curious if you think there are certain populations that you commonly see that are underscreened that you'd like to highlight.
Well, in general, we are pretty poor at screening for osteoporosis, unfortunately, and we're even worse at treatment, which is really sad. So even now, only maybe about 15% of people are on treatment a year after a hip fracture, which is really quite shocking. So I think we are under screening and we're definitely under treating. And since it's a silent disease, it's very easy to forget about the bones, both for the patients and for the physicians and other providers, because there's so many other things going on in a pressured time of a clinic visit. So it's definitely something we need to get better on our radar screens and can be very helpful. The other thing that I think is very helpful to remember is that, the FRAX calculator, which we use to predict fracture risk, you don't have to have bone density in order to use the FRAX calculator. So if you use the FRAX calculator without putting in a bone density, it substitutes BMI instead of bone mineral density, and it actually works really, really well. So if you have somebody and you're like, I don't know if this person should have a DEXA or not, you can just put them into FRAX and see what you think their fracture risk is. And that may tip you one way or another to saying, this person probably needs a bone density.
Oh, great. I didn't know that. I've never calculated a FRAX without the bone density. So thank you for
Yeah, and
sharing.
in fact, in the UK, bone density is much more restricted, and they use FRAX as the initial screening. If your fracture risk is very low, you don't get a bone density, you don't get treatment, and just nutrition and lifestyle factors. If your fracture risk is quite high, then you don't get a bone density either. You just get treatment, and so they really only do bone density for people in that band where their risk is kind of indeterminate, and bone density would push them one way or the other. So it's actually quite effective to use FRAX as an initial screening tool.
Oh, it's always interesting to hear how other countries have differences in their screening guidelines.
It is.
Yeah. And then I'm wondering, so if someone who has multiple risk factors, and let's say I calculate their FRAX and it's concerning, is there an age that's too young to start DEXA screening? Is DEXA useful in younger patients?
It's probably less helpful to do screening in sort of asymptomatic folks under 50. So premenopausal women and men under 50. And a big part of that is the risk of fracture is so low in those populations, even if they have low bone density. So if you get a low bone density, it's not even really clear what you should do about it or if it's helpful to treat. And part of that is also just looking at kind of the risk reduction we can get with our medications. So our medications are extremely effective, reducing fracture risk by 50 to 70%. But those are relative risks. And so if the patient's absolute risk is already very low, say a 30-year-old whose 10-year risk of fracture is 4 or 5%, you reduce that by 50%, you're only going from 5% to maybe 2.5%. And so you're not getting anywhere near as much bang for your buck in a low risk population. And so that's why screening is not particularly helpful in those younger folks. Now, that being said, there are definitely people who should be getting bone density, and largely anyone who's had a fragility fracture, or people who, again, are on medications that compromise bones, people who have nutritional status that compromises their bones, whether it's anorexia or inflammatory bowel disease or gastric bypass surgeries, those folks should be getting bone density because they are at increased risk for fracture and bone loss, and treatment can be helpful in them.
I see. And when we're looking at those numbers, we're mainly looking for the lowest T score to decide if someone needs to be on therapy. And is it women that are less than 50, or do I have that incorrect where we're looking more at their Z score?
Correct. So the Z-score is comparison to average bone density for the person's age. And so that's what we use in folks under 50 and premenopausal women. So because bone density is normally distributed in the population, we generally use a Z-score between +2 and -2 to constitute expected bone density for age. And so if your Z-score is less than -2, then we say, okay, your bone density is low compared to the average expected for age. But also you have to remember, because of that normal normal distribution of bone density, 2.5% of the population are going to have a Z-score less than -2. And those people are not all fractured. So you don't want to label those people really with osteoporosis. What we really want to say is, okay, your bone density is low compared to average for your age, and then assess them for evidence of skeletal fragility. And if they've never had a fracture and they're doing fine, then we'd say, okay, you just need to be vigilant, especially around the time of, if it's a female, especially around the time of menopause, because you're already starting out on the low side. Your risk right now is low, but we don't necessarily want to let you go through menopause without some treatment, because you're going to get quite low because you're already starting a little bit behind the 8 ball.
Right. And when we order a DEXA scan, it's generally done at the spine and the hip. And I'm wondering, how can the T score be impacted by things like osteoarthritis or degenerative disc disease?
Both sites can be impacted by degenerative disc disease, although the spine is much more susceptible to those artifacts. And so the spine can sometimes be quite elevated by disc disease and also fractures too. So if there's fractures in the vertebral bodies, that will increase bone density as well. So one tip that you're having a significant impact by degenerative disc disease is if there's a lot of variability among the individual spine bones. So generally, the T-scores among the 4 lumbar vertebrae that are usually assessed should be within about a half a standard deviation of each other. If you've got more spread than that, the high ones may very well be a bit artificially elevated due to DJD in the spine. And so it's helpful to have both the spine and the hip because then we can kind of get a little broader feel for the bone density. And if there's much lower bone density at the hip than the spine, and there's evidence of DJD at the spine, then that bone density at the spine may not be as helpful to you in terms of assessing fracture risk. And then sometimes we'll do the forearm. Some places routinely do the forearm, some places do not. It's a separate CPT code, so it has to be ordered separately. And that's, I think, why most people don't get it, because there's a single CPT code for spine, hip, both hips. All of that is one CPT code. The forearm is particularly helpful in settings where cortical bone is going to be affected, like hyperparathyroidism, because that 1/3 forearm is 99% cortical bone. It's also helpful in settings where people cannot get positioned properly to do a spine and a hip. So, people are in a wheelchair or other assisted device, or sometimes people are a little bit too large for the bone density machine. There are some of the older machines have weight limits at 300 pounds. Many of them now are up to 450. So we usually can get bone densities, and that's really been important for the bariatric population. But if folks have mobility limitations or machine limitations, many of them are able to at least get the arm out and get it into position so we can get a bone density at the arm.
I see. And then I've noticed for some of my patients who've gotten the forearm scores, incidentally, that they tend to be a lot lower than the other sites. Is
They
there?
can be. And so then in that setting, you want to make sure the parathyroid is normal, but it often is. And sometimes people are just particularly low at the arm. And so if they're got pretty good bone density at the spine and the hip, they're on the younger side, their overall fracture risk is not that high, but they have isolated osteoporosis at the forearm, then I just kind of look at their overall fracture risk. And if it seems like overall they're probably pretty low, I may not treat based solely on the forearm. If they're older, even if their FRAX is not quite to the treatment level, but they're older, they've got osteoporosis at the forearm, then I might lean more towards thinking about starting them on therapy. And then you can monitor the forearm as well as you're monitoring the other sites and make sure that you're doing well. In terms of therapeutic options, the PTH agents like teriparatide and abaloparatide, they decrease bone density at the forearm. And so if you've got somebody who's particularly low at the forearm, that may not be your first choice. It's not, risk factors do not go up on those agents, so it may be an artifact of how the bone is expanding with exposure to those PTH agents, and it may not actually be a decrease in skeletal strength, but it will go down. So if the forearm is your primary reason for treating, those may not be your best option. And on the other hand, Denosumab is the one agent that can increase bone density at the forearm. Most agents, it just stays stable, but it does tend to go up on Denosumab and it tends to go down on PTH agents. So those are considerations you might have if the osteoporosis is limited to the forearm site.
I see. Okay. And then just to confirm something you said earlier, you mentioned that DJD can increase the T-scores, right? So if I know someone has significant DJD and let's say their bone density at their spine is negative 2.3, it may in fact be lower in the osteoporotic range. Okay.
Correct.
Great. And then most fractures occur in the osteopenic range, and that's part of the reason we use the FRAX score to decide if someone warrants treatment. Are there certain patients where the FRAX score might underestimate the risk of fractures?
Sure. So in the FRAX calculator, the only bone density site you can put in is the femoral neck. They also have run it with total hip, and femoral neck basically behave the same. So those are equally valid, but the only sites you can use are the hip, and the one that is out available is specific to the femoral neck. And it was designed that way because of the DJD at the spine and the variability at the spine, and because hip fractures are the most devastating fractures. And bone density at the hip quite well predicts whole body fracture risk. So that's why it was limited to the femoral neck. But because of that, if people are better at the hip than they are at the spine, then the FRAX may be underestimating their overall fracture risk. And so that is partly why the treatment guidelines still include having a T-score below -2.5, is to try and capture those people who have bone density in the osteoporosis range at the spine, but aren't meeting criteria by FRAX at the hip. And so that gets a little bit complicated about fracture risk versus T-score, but that's part of why the recommendations still contain the T-score, is because we're trying not to miss people who are at risk because of osteoporosis at the spine, but the hip isn't low enough to get them into treatment via FRAX.
I see. And speaking of the spine, the American Association of Clinical Endocrinologists recommends screening for vertebral fractures. So, who should be screened for vertebral fractures and how can this be done?
This is a big issue which has not gotten as much attention clinically as it should. Two-thirds of vertebral fractures are silent. So only one-third of vertebral fractures cause enough symptoms that the person seeks medical care and is diagnosed at the time that the fracture occurs. And I think it's because back pain is just so prevalent and people injure themselves not infrequently, and you just treat it conservatively and it goes away in 6 weeks and you don't realize that you had a fracture. So there's a couple of really important things about that. One is the clinically silent fractures portend the same increased risk of fracture and the same increased risk of mortality as clinically evident fractures. So if you get a chest x-ray to rule out pneumonia, or the person has a CT scan for a kidney stone and a fracture, a vertebral fracture shows up, that needs to be taken seriously and not as an incidental finding. That is just the same as if the patient showed up on your doorstep having acute back pain and you found a vertebral fracture. So they should get the same attention as people presenting clinically. Because they're silent, though, we miss a lot of these people. And so one thing that can really help is height screening. And so generally, if people have lost 2 inches or more of height from their maximum adult height, that is a sign that they may have a vertebral fracture and should prompt imaging. So that certainly should prompt imaging, but there are actually guidelines even for people who don't have any height loss. The ISCD puts these out about getting asymptomatic vertebral screening in quite a number of people with low bone density. So it's based on kind of age and where your bone density is, but if you look at those guidelines, it's a large percentage of people with low bone density should have screening for asymptomatic vertebral fractures, because they're so prevalent and have such implications both for treatment and for patient morbidity. So it's the ways you can screen. You can just get x-rays, thoracic and lumbar spine x-rays. There's also something called vertebral fracture assessment, which can be done if the bone density machine has the software to do it. And it's a lateral DEXA view that looks at vertebral heights. And so if the height of the vertebra is decreased by 40%, it's a moderate fracture. If it's decreased by 20%, it's a mild fracture. So you can pick them up on DEXA if the facility you're using's bone density machine has that software. Figuring out who's got a vertebral fracture, a prevalent vertebral fracture, is very important because our treatment guidelines and duration of treatment vary on whether or not there is a fracture present. So the vertebral fractures are the one kind of fracture that goes up when people go on a medication holiday. So we treat those people longer. So for example, with an oral bisphosphonate, we'll often treat 5 years. And if you don't have any vertebral fractures, you're out of the osteoporosis range, we do a medication holiday then. But the 2 groups of people that have been shown to benefit from longer term treatment are people who are still in the osteoporosis range, especially at the femoral neck after that first 5 years, and people who've had vertebral fractures. So if the vertebral fracture is silent and you haven't screened, you won't know if that person should have 5 years of treatment or 10 years of treatment. And so that's why there's pretty liberal guidelines for getting vertebral imaging in most people with low bone density. But it's a little tricky to do if they have to go get x-rays, which is why the VFA is such a great thing, but it's not as widely available as we would like.
I see. So if someone has an asymptomatic compression fracture and they've been on Fosamax, when would be the soonest that you would consider a drug holiday for them?
It would be a full 10 years of treatment.
Okay.
Yeah, so the alendronate trials compared 5 years of treatment to 10 years of treatment. And the predictors of women who had less fractures if they stayed on treatment, one was having a hip bone density, femoral neck bone density less than minus 2.5. So still in the osteoporosis range after that first 5 years of treatment. Fracture rates stayed low in the women who went on the medication holidays, but the one kind of fracture that went up was vertebral fractures. So if people have had a vertebral fracture, we go longer with treatment and get the full 10 years before medication holiday.
Okay. And I think some providers assume that 10 years is also the maximum duration. I've seen people think about terminating and after 10 years, but can some patients benefit from course longer?
Absolutely.
Okay.
So our data go to 10 years with oral bisphosphonates and go to 9 years with intravenous bisphosphonates. And so because of that, once you're past those timeframes, you're kind of on clinical judgment about when to go back. And so one thing we want to make sure people and patients understand is that medication holidays are holidays. They're not retirements. This is not a permanent cessation of medication. And fracture rates are low for, even 5 years, maybe even more after a course of bisphosphonates. But people have normal bone turnover. And I would say, reassure patients, this is what we want. We want bone turnover. We don't want old, dead, static bone. We want you to be turning it over. But the implication of that is that you're freeing up the drug. And so when time this drug is going to wear off, but we try to detect when it's going to wear off. We don't go back to treatment until we think your skeletal load of bisphosphonate is too low to be protecting you. And we're basically, resetting the clock. And so we watch bone density. We also watch markers of bone turnover, which are collagen proteins that come out of bone when bone is being broken down. So you kind of just try to get a gestalt. Maybe the bone density is drifting down just a little bit. You don't really want to wait until there's been a huge amount of bone loss. Just start seeing that bone density drift down, see those markers of bone turnover start drifting up, and you're like, you know what? I think that bisphosphonate is wearing off. And sometimes it takes a couple of years to be confident that it's truly wearing off, and you're like, there's some early signs. Let's see what next year looks like, and then you start getting a consistent pattern, and then you say to the patient, you know what? It's gone. We need to go back to treatment, and then you can go back to whatever you want. You can do bisphosphonate again, or any of our other medication options.
Yeah, you mentioned bone turnover marker. That's not something I routinely order. I'm just curious. So it sounds like you use them when people are on drug holidays. Are there other instances that you commonly use those bone turnover markers to help you make a decision point?
Probably the medication holidays is the number one time that I use them. The other time that it's really helpful is if somebody is on an oral bisphosphonate and it's not going well, they're losing bone or they had a fracture, then it's helpful to get the bone turnover markers because the oral bisphosphonates are tough to absorb and the adherence may not be the greatest. And so what you really want to discern is this person getting enough bisphosphonate on board? And the bone turnover markers can help you do that because if they're taking the oral bisphosphonate, they're absorbing it properly, those bone turnover markers should be in the lower half of the normal range. If they're not in the lower half of the normal range, then the person is not getting sufficient exposure from that oral agent. Either they're not taking it or it's not being absorbed. And so then you can just switch to a parenteral anti-resorptive agent like zoledronic acid or denosumab. If those bone turnover markers are low, which tells you they're taking it, they're absorbing it, bone resorption is low, then that's going to steer you toward an anabolic agent because switching, if they're already in a low turnover state, there's not really any point in giving them more anti-resorptive. You're going to want to switch to an anabolic agent. So those are the two predominant times that I order them. The bone turnover markers have suddenly moved into the lay press and patients are calling and they all want to know their bone turnover markers. And They want them monitored so they can tell if the medication is working, and there's just not really any data to support that. So I try to discourage that, because if it's not going to change my treatment approach, then I don't really see there's any value in getting them just to kind of see what they are, which is currently very fashionable for some reason. It has really hit the late brows.
Oh, yes, I can say for a lot of labs, that definitely applies. And then when someone is either on treatment or not, for their osteopenia, osteoporosis, how often are you recommending rescreening with the DEXA?
This is a tough question, and it's very much provider driven. And I will be the first to confess that I get a lot of DEXAs, and I monitor a lot. And part of the rationale for that is it's an extremely low X-ray exposure, and it's very cheap these days. You know, the Medicare reimbursement for DEXA, I think it's down to like $42. So I feel like there's almost no downside. And the thing I hate the most is to go 2 or 3 years and somebody's lost bone. And then I feel like, I could have caught this 2 years ago and done something. And, so then I regret it. So I think it is particularly helpful to get a bone density 12 to 18 months after you've started a treatment, because you want to make sure a person's bone density is at least stable, if not improving on treatment. And so I generally get one fairly soon after I've started treatment. And then after that, I think you kind of tailor it to the individual person and the agent that they're on. So if they're on a parenteral agent, it is quite likely they're going to, and they've had one DEXA that's been fine, it's quite likely they're going to be fine as long as you have them on that parenteral agent. And so then I think you don't need a DEXA very often. I usually get them before I switch to a different agent. I think it's also really helpful to get it at the time points that we consider medication holidays. So after 5 years of oral or after 3 years of IV, then I think you need a bone density. The other time that I get them more frequently is in people who are on a medication holiday, because while we do have data that fracture rates stay low for 5 years after 5 years of oral bisphosphonate, the bone density was going down during that 5-year period. And so I try to catch people when they start losing bone so we can intervene. Although I will grant you that it's a little bit tricky because, okay, the bone density went down, but fracture rates still stayed low. So should you really be going back to treatment based on bone loss, that fracture rate may not be elevated. And I don't know the answer to that, but I think it is tough to let people lose bone. So generally during a medication holiday, I'm watching it pretty closely every 12 to 18 months or so, to try and get enough signs that when we need to end the medication holiday and go back to treatment. And then in terms of sort of screening, I think that's when things can be spread out more, because then you can kind of see where the person is and what their anticipated rate of bone loss is to decide when you're going to get your next bone density. So for example, if someone is kind of in the perimenopausal period and they're starting out at, maybe minus 1.8 or minus 2, they don't need treatment then, but they're perimenopausal and they could lose 5 or 6% per year and be osteoporosis within a year. And so that person might need another bone density in a year to see, are they losing that fast? Is now the time to treat? If they're past that rapid bone loss, they're 65 or something, and they have a minus 1.5 or minus 1.8, the average rate of bone loss at that age is about 1% per year. So it's going to take them, 5 or 6 years to get osteoporosis if they're even losing bone. So that person might not need another bone density for 5 years. So I think I try to kind of tailor it to the clinical scenario and the age and expected rate of bone loss that the person has.
I see. So it sounds like for you, it's somewhere between 12 months and 5 years, depending on the patient.
Exactly. Yeah, it could be as little as 12 months or as much as 5 years. And the variability in the bone density measurement itself is around 3.5% at the spine, 4.5% at the hip. So there's not really any point in getting them closer together than being able to see that rate of bone loss. So that's why in somebody who's 65, who may only lose 1% in the next year, there's no point in getting a bone density the next year, because it's just not going to be different enough to change your treatment plan.
I see. Okay. And then moving on to lab tests, we talked a little bit about bone turnover markers. What laboratory assessment do you think should be done on pretty much all patients with osteopenia or osteoporosis?
They're all kind of our current guidelines, expert opinions recommend getting some labs. They are not exactly the same based on which expert you're talking to. And there's not a lot of data on this. There was one kind of systematic series in osteoporosis patients that's now 20 years old, which showed that vitamin D and parathyroid, serum and urine calcium are the most prevalent abnormalities. So those have long been kind of recommended to be examined, although I think people may or may not be as comfortable with getting 24-hour urine samples. And then the other things that that show up all the time, celiac keeps poking its head up, and it was about 1% of completely asymptomatic people in that series. And so we actually embarked on an assessment of laboratory utility in our clinic. And so we have kind of a standard set metabolic panel, phosphorus, which you have to order separately. People always forget about phosphorus. So metabolic panel, complete metabolic panel, phosphorus, vitamin D, PTH, 24-hour urine, and like a TSH, some assessment of thyroid. So among that panel of tests, we did a retrospective review of 890 consecutive patients, and 67% of people had at least one abnormality on that set of tests. So that set is very high yield. And shockingly, this is now 20 some years since that original publication. Vitamin D and PTH are still the two most common abnormalities and are abnormal in over 20% of people, which is really kind of shocking that we still have that much vitamin D and PTH abnormalities. And then the celiac rate was 1.5%. It's still the same. It's still about 1.5%. And I think it's worth keeping in there, even though it's relatively low, because these are people who are completely asymptomatic, had absolutely no idea they had celiac, and had been getting medical care, and no one had ever picked up that they had celiac. So I think it's still worth keeping in there, because I just can't come up with any clinical way to figure out who to screen for celiac in terms of people with low bone density. And then the urine results were very interesting. We were only successful in getting urine in about half of the people who came. But over half of those urines were abnormal, and it was equally split between hypocalciuria and hypercalciuria. So the urine calcium is an extremely high yield test, and it's probably worth fighting through to get it done.
Yeah, you had sent me that paper from 20 years ago for a separate project, which since then I've ordered a lot more 24-hour urine, since it's the most amount of missed disorders if you don't do it in the first rung of evaluation, was what that study showed. But I feel like most providers, including myself, aren't super comfortable interpreting a 24-hour urine test. Can you give just kind of a brief overview on how we should interpret the results? Let's say the PTH and vitamin D are normal.
Sure, and I think that's exactly right. You really want to be looking at the urine calcium in conjunction with the PTH and the vitamin D. And so as a general guideline, if the 24-hour urine calcium is under 100, that's probably low. And in general, if it's over about 250, that's probably high. So sort of just looking at those flags initially, and then looking at the PTH and the vitamin D. The low urine calcium is basically just telling you that the patient needs more of either calcium or vitamin D. And if the PTH is high, then it really tells you that they need more calcium and vitamin D, as long as their renal function is normal. So it can help you tell when somebody's got to get tanked up. And assessing calcium intake is a little bit challenging, but what's impossible to measure is calcium absorption. And we don't know how well people are absorbing calcium. And the 24-hour urine calcium and the PTH are the only markers we have to tell if we've got somebody in decent calcium balance. So if the PTH is on the higher side, that urine calcium is low, that is telling you that person needs more calcium. And even if they're taking the 1,200 we recommend for everybody, they aren't absorbing it, and they're not getting enough to be in neutral calcium balance. So that low urine calcium can tell you that somebody needs more calcium or might need more vitamin D. If vitamin D is low, that will lower the urine calcium as well. And then on the high side, about 40% of men with low bone density have hypercalciuria as a contributing factor. It's about 10% of women will have hypercalciuria. And it's probably just a renal set point for calcium excretion, which again is normally distributed in the population. But the folks that are on the high end have a tendency to get kidney stones, and they also have a tendency to have low bone density because they've just got this lifelong drain of calcium out of the system. So for those folks, we have a lot more data in men with kidney stones. For whatever reason, men tend to show up with kidney stones. Women tend to show up with low bone density. So it's not always picked up in women that they have hypercalciuria unless you're really looking for it. But men come to attention because they have a more of a tendency to get kidney stones. So in the men with kidney stones is where we have most of our data. But in that population, if you lower urine calcium with low sodium diet, high potassium diet, thiazide diuretics, their risk of kidney stones goes down, but bone density also tends to improve. And in unselected populations, there's actually a thiazide randomized trial that shows a reduction in fracture risk with thiazides in an unselected population. So I think that high urine calcium does have an impact on bone health, and there are relatively straightforward things we can do to get that urine calcium down that not only protects the kidney and protects against kidney stones, but actually improves bone density as well.
So if a woman has hypercalciuria, you're telling them a low sodium diet, possibly a thiazide, and then what do you tell them about their dietary calcium?
So we really want them to have adequate calcium intake. So I have had people sent to me who had a hypercalciuria and they were told to stop all their calcium supplements, go on a low calcium diet. So first of all, that's not super effective actually at lowering the urine calcium because it's a kidney set point is the issue. So the kidney's just going to keep putting out the same amount whether or not you're getting in. It may bring down the urine calcium a bit, but the bigger issue is if you're not getting enough calcium in through your GI tract, the body's just going to pull it out of the bones. So now you're using your bones as your calcium source in addition to dumping the calcium in the urine. And so that makes things way, way worse on the calcium front. So we want people to have an adequate calcium intake and concurrent with that, do strategies that are going to lower that urine calcium. And I definitely have had people where it's really hard to get that urine calcium down, and maybe I'll back off a little bit on their intake, get them a little closer, maybe 1,000 instead of 1,200 milligrams. But in general, we don't want to make people calcium deficient as a means to try and get their urine calcium down. We want to do the things that can lower urine calcium instead, because that will improve their calcium balance and not have them using their bones as their calcium source.
Okay, got it. Glad I clarified that. So then kind of moving on to treatment, which we've touched upon here and there. So one aspect of it is calcium, and we often are recommending to patients to do that 1,200 milligrams dietary calcium supplement as needed. What are some common mistakes you see patients do in terms of their calcium supplementation?
I think some of the common mistakes, the biggest one is understanding the food label or the supplement FRAX label. And so there's often an amount of calcium that's on the front label, and people assume that that is the amount of calcium per pill, which is rarely true. And so if they have a bottle that says 500 milligrams of calcium, they just say, oh, each pill is 500 milligrams. But you really have to look at the supplement FRAX label and see what the serving size is, because that amount is per serving, not per pill. And so it's not uncommon, especially if it's calcium citrate, that it's 2 pills to get 500 or 600 milligrams. So I think that's the first mistake that people make. I think the other mistake that is very common is to figure out how much dietary calcium people are getting. So even a diet with no calcium-rich food is going to have around 300 milligrams of calcium. And so the most anybody needs to identify in their day is around 900 milligrams. So generally kind of 3 servings of calcium-rich food like dairy foods or calcium-fortified foods. There's orange juice. The calcium-fortified plant milks are a great source of calcium these days. Lactate, the lactate treated milks, they have 500 milligrams of calcium. They're actually calcium-fortified milk, which is a kind of a funny concept. And then other good sources, tofu is a great source. If people like, the canned fish that has bones in it, that's a great source as well. The leafy greens can contribute. They have about 80 milligrams per cup. I think the other mistake that people make is understanding that that is a measurement of uncooked vegetables. So something like broccoli is going to stay the same size whether you cook it or not, and the calcium stays the same. So that's easy. But something like kale, it's 80 milligrams per cup of uncooked. It wouldn't be feasible to eat 5 or 6 cups of kale as a salad, but you could eat 4 or 5 cups of kale if you cook it. And so, if you really want to try and get a lot of calcium from greens, you can get it by, cooked kale is a great way to try and do that. The calcium in spinach is not bioavailable. It is internally bound to phytates and oxalates. So a lot of times people think of spinach as a calcium-rich food, and it is, but you just can't absorb it. But because it's internally bound, it's not going to mess with the calcium from other foods. So if you have a cheese and spinach omelet, you're going to absorb the calcium from the cheese. You just can't count the spinach calcium as part of your intake. Among the calcium supplements, the calcium citrate is probably the easiest to absorb, but it also has the least amount of elemental calcium per pill. So if you use calcium citrate, you can take your supplement any time of day, but you will probably need more pills than if you use calcium carbonate. People typically say if you take calcium carbonate, you have to take it with food. But if you dust off that New England Journal article from, I think, about 1983, that was actually only true for people who had achlorhydria. So people who had intact gastric acid, it didn't matter. They could take the calcium carbonate on an empty stomach and have perfectly good absorption. But I will grant you that the challenge is knowing who's got achlorhydria, and that becomes more prevalent as people get older. So it probably does make sense to tell people to take carbonates with food. But in fact, it's only a factor if you have achlorhydria.
Interesting. And then for the vitamin D, is a goal over 30 sufficient, or are there certain populations that you recommend even a higher level?
Over 30 is sufficient. So there is discrepancy among vitamin D recommendations. And I think one of the big things that people forget about with the Institute of Medicine is they're setting what's called an RDA. And the RDA has a very specific definition, which is the average amount of the nutrient that is sufficient for the health of 97.5% of healthy people. So it's a different population than Endocrine Society is talking about or ASBMR is talking about, because those organizations are concerned about people with skeletal fragility. And so I've never been able to find what actually healthy people means from the Institute of Medicine standpoint. But you could argue that people with osteoporosis are not healthy people in the sense of vitamin D needs. So there's, I think, a huge body of literature that supports that having a vitamin D level over 20 is probably fine for a great number of people. But there are still people who have secondary hyperparathyroidism, people who still have undermineralized bone, people who still have clear evidence of vitamin D deficiency, even with vitamin D levels between 20 and 30. Over 30, none of the data shows anybody is deficient. So I think once you're over 30, there is no evidence that you need to be really any higher than that. And importantly, there's no evidence of any harm in the 30s compared to the 20s. So even the most staunch defenders of a vitamin D level of 20 will say, yeah, there's no harm being in the 30s. So kind of my take on it is if there's no harm to being in the 30s and there's benefit to at least some people to being in the 30s, we should be shooting for over 30. And so there doesn't seem to be any reason to get over about 50 or so. And people will start getting hypercalciuric with high vitamin D levels, probably at least 90 or 100 to get hypercalciuric and over about 125 to get hypercalcemic. But there's just no benefit to being at those levels. So if patients ask me what range are you looking for, generally, I say 35 to 50 or 60, something in that neighborhood. I try not to have people clinging to the very bottom of the normal range because there is about 10 to 15% assay variability, and there's about 10 to 15% seasonal variability, even in climates where people are not getting as much sun. So there's no reason to hang out at the very bottom because you probably are a little bit low sometimes of the year. So I think anything between 35 and 50, even up to 60 would be fine.
Okay, I see. And then let's jump into kind of prescription medications. Before we do, I wanted to ask you what your opinion on menopausal hormone therapy in postmenopausal women with osteopenia is from an endocrinology perspective, assuming that there's no other contraindications.
These days, we aren't really using estrogen so much for bones. And the reason for that is the only estrogen fracture trial that's ever been done was the Women's Health Initiative, and that used that full 0.625 Prem-Pro combination. So in that study, estrogen reduced both spine and hip fractures by about 35%. And so, for example, something like alendronate reduces fracture risk about 50%. So while we don't have head-to-head studies, it suggests that even at the high doses, estrogen is less effective than our other treatment options. And those WHI studies were all stopped because of vascular things and breast cancer and all of that. So these days, I'm not aware of anyone who's still using those higher doses of estrogen, and that's the only fracture data that we have. So the low doses of estrogen are very effective for hot flashes, vaginal dryness, kind of perimenopausal symptoms. They do tend to maintain bone density, and for women who are clearly postmenopausal, you'll even get a few percent gain in bone density if you start the low dose estrogen. We just don't have any fracture data, and so I don't know if there's a dose response or not, but if the high dose only reduces fracture risk about 35%, kind of makes sense. There may not be a whole lot of fracture protection at the low doses, but we just don't know because there have not been any clinical trials. So in general, we don't use estrogen specifically for bone, but it is something to keep in mind in women who are on estrogen for other indications because their bone density quite likely will stay stable, even if they're in kind of that early postmenopausal time frame. Those low doses are usually pretty effective at keeping bone density stable. So I think it can kind of delay when you need to think about osteoporosis treatment if people are on estrogen supplementation. There is very limited data on osteoporosis medications used in conjunction with estrogen. There's one trial that's pretty small, which showed a slightly higher increase in bone density with combo therapy compared to the bisphosphonate or the estrogen alone. It was not additive. It was a very small increase in bone density and no fracture data. So you may get just a very small increase in bone density by adding an osteoporosis agent in. And of course, we do worry about over-suppressing bone turnover and bone remodeling. So I'm not crazy about the thought of having two anti-resorptive agents on board, especially if I know bone density is likely to stay stable on low-dose estrogen. So it's just kind of a conversation to have with the patient, but I do make sure they understand that if your point in taking estrogen is for your bones, then this is not the point of doing it. If your point in taking it is because you need it for hot flashes or something, great, and we'll keep an eye on the bones. But bones should not be your rationale for taking estrogen.
Right, right. So if I start someone on, let's say, an estradiol patch 0.05 for their hot flashes, and at the same time I know that they, let's say, have a T-score of negative 2.7, would it be reasonable to just repeat that DEXA in 1 year to see what happens on the low dose estrogen instead of starting them on a Fosamax or something right away? Okay.
Yeah, absolutely. And the women who are taking estrogen tend to be on the younger side, so their fracture risk is going to be on the lower side. And so, a 50-year-old woman with a T-score minus 2.7, her 10-year risk of fracture, if she doesn't have other risk factors, family history of hip fracture and stuff, her 10-year risk of hip fracture or 10-year risk of fracture is not that high. So it's entirely reasonable to just monitor bone density as long as they're on the estrogen. And if the bone density stays stable and you can throw them into FRAX and kind of see what their fracture risk is, if their fracture risk is not that high and bone density is staying stable, it's entirely appropriate to stay on estrogen and wait for osteoporosis agents until later.
Okay, got it. And then jumping into those prescription medications, I think many primary care providers are very comfortable prescribing Fosamax, maybe reclass if there's GI contraindications. When would you opt for Prolia as your first line choice? I think you also mentioned that having very low forearm scores was perhaps an indication.
So the low forearm would be one reason I might think towards Denosumab. Denosumab does increase bone density more than the bisphosphonates do. Now, whether that results in lower fracture risk or not, we don't know because there haven't been the head-to-head trials. And the risk reductions with Denosumab and with zoledronic acid are identical for the 3-year placebo-controlled fracture trials. So they do have a little bit different effects on bone density with larger gains on Denosumab, but at least within the 3-year placebo-controlled trial, the fracture protection looks very, very similar. So it makes it hard to make judgments because we're careful about extrapolating from bone density changes because they're just not as reliable at fracture prediction as we would like. Unfortunately, it goes in the good direction. Even very small gains in bone density can result in very large reductions in fracture risk, and fracture risk goes down considerably more than we would guess from the relatively small changes in bone density. And it's because bone density is only one piece of bone strength. So there are many other bone architecture. There are very small connections between the struts in bone that are being made that is just enormously contribute to bone strength, but are so small that DEXA is just not going to pick that up. So fortunately, it's in the good direction, but it does make it a little, it does reinforce to us that we need to be a little cautious about extrapolating between changes in bone density and differences in fracture risk. Denosumab was in clinical trials for 10 years, and over that 10-year time point, bone density continued to increase, and fracture risk actually got lower with longer-term treatment. So we have really good long-term clinical data with denosumab with progressive gains in bone density. So if somebody is starting out particularly low, I might lean toward denosumab over a bisphosphonate, but I do always discuss with the patient that we are limited and that we do not have head-to-head fracture trials. So I can't guarantee that the fracture risk is going to be lower, but we all do enjoy watching bone density go up. I'm afraid it's hard not to be swayed by that.
I see. And so I know that the AACE, one of the very high risk features is having a T score of less than -3, which I don't see uncommonly. Assuming I've kind of ruled out secondary causes, it sounds like denosumab might be a preferred therapy over Fosmex for someone with a T score less than -3?
Yep, I would agree. I think certainly over an oral bisphosphonate, it would. I think it's reasonable to think that denosumab is going to be more effective than an oral bisphosphonate. And I think it also kind of depends on the person's overall fracture risk. Also, renal function. If the renal function is a little less robust, denosumab can be an attractive option there, although the risk of hypocalcemia on denosumab is much higher, is much more significant in folks who have CKD. So you just have to be a little bit careful about making sure they're fully tanked up on calcium and vitamin D. And I do kind of warn them a little bit about symptoms of hypocalcemia. And if they develop anything, to let us know.
Okay, and denosumab also has risks of osteonecrosis of the jaw and atypical femur fractures as well.
Correct. Yep. The risk of ONJ and atypical femur fractures, it looks to me to be pretty similar among bisphosphonates and denosumab. I can't say that I think it's any different for any of those agents. It is very rare. The big thing that plays into with denosumab therapy is that you can't take a medication holiday directly from denosumab. So the antibody is gone in 6 months, and bone loss picks up very quickly. Fracture risk rises very quickly, and there have been instances of people experiencing multiple vertebral fractures with just stopping the denosumab. So what we do is transition to a bisphosphonate and then transition to medication holiday. And so it probably takes at least 2 years of bisphosphonate, 2 annual infusions of zoledronic acid, or at least 2 years of oral bisphosphonate to transition off of medication completely without incurring bone loss. So I take that into account when I'm thinking about overall duration of treatment, recognizing that I'm probably going to have to do a couple of years of bisphosphonates. So I kind of time my denosumab. If I'm thinking this is a person who needs 10 years of treatment, I might make the switch at year 8 or something like that, so that I've got their full, their anti-resorptive done in about 10 years. But that is still something we're still learning about, is how much bisphosphonate should a person have after denosumab, and are there particular durations of treatment where it's better to switch, at certain time points, and that we're still learning about.
I see. And I feel like osteonecrosis of the jaw, atypical femur fractures are often reasons patients don't want to consider these therapies. And I tell them the risk is so low, 2 to 3 in 10,000. It's more likely to be struck by lightning in Minneapolis. I know there's in that one slide, but I still won't take it. I'm curious what your counseling points are to convince patients to take on these medications.
Yep. And so for the osteonecrosis of the jaw is exceedingly rare and almost always happens in the setting of a dental procedure. And so I just advise, patients, keep up with your dental work. We want to make sure you don't need anything before we start the medication, and then just let me know if something's needs to be done. With bisphosphonates, there's no evidence that stopping the medication has any impact on the incidence of ONJ. But with bisphosphonates, if they bind to bone, if somebody wants to stop bisphosphonate, the patient or the dentist wants to stop it for the dental work, I don't care. I don't think it's going to impact their fracture risk to be off for a few months. But you'll get varying recommendations from dentists, and everybody's, making up their own regimen. There's no standardized approach to this. But generally, if it's just a few months and I don't think it's going to impact the patient's fracture risk, I don't care. Do whatever you want with the bisphosphonate. And I also tell patients that too, especially if we need to think about zoledronic acid, because they've had GI symptoms on an oral agent or something, let me know if it's an urgent thing, just get it done, whatever it needs to get done. If you've got the luxury of time, then we'll try to get you as far out from your infusion before doing the dental work. We can delay the next infusion till everything's done and healed up, kind of help them understand we can manage this to try and make everybody comfortable with getting you through your dental work. Denosumab is a different game, though, because you can't stop it. And so you can't stop it. I really don't want to delay doses for more than about 2 weeks because I've seen those multiple vertebral fractures happen in with just like 3 or 4 weeks off treatment. So what I typically do is, and I tell patients this before we start, so they're at least aware of this, I usually do the dental work about 3 months after the last injection. So at that time point, bone remodeling is starting to pick up. So bone turnover goes down right after the injection. Around the 3-month time point, it starts coming up. Now, it's still low. It's still well below baseline, but it is starting to pick up. So bone remodeling is starting to pick up, and that also gives us 3 months to make sure everything's going to heal up and they're going to be doing okay before the next dose. So it gives us time to make sure we're okay and we're not going to give them a dose, right after the procedure, and then they felt ONJ and it's on board for 6 months. So I usually do it at 3 months. There's not great data for this, but it seems to work well. And I can also show the dentist the little graph where the bone turnover is coming up at 3 months, and usually we can get through that. So ONJ, I think, is not as big an issue because it is so much more rare. The atypical femur fractures are a devastating event, and we definitely want to avoid those. And so what I think really helps patients understand is that the risk of those atypical femur fractures falls by 50 to 70%, even in the first year off of medication, which we don't understand. That makes no sense. The amount of bisphosphonate in your bone a year later and the rate of bone turnover a year after stopping treatment is indistinguishable from 12 months prior. So I don't know why that's true, but it's been seen in at least 3 studies now where that risk falls dramatically, even in the first year. So patients find that very reassuring. So, sort of explain to them the concept of the medication holiday and how the medication holiday can really help prevent these rare side effects and how we're going to be monitoring. We're not going to just, turn you loose and see you in 10 years. We're going to keep an eye on things, and if there's any, reason to stop sooner, we'll definitely do that. But we can manage this rare complication.
I see. And then I've seen articles that mention that Asians have a higher risk of atypical femur fractures on bisphosphonates. And I'm curious if you have a different threshold for drug holidays for Asians, given that they tend to have a higher risk.
So I do tailor treatments a little bit in women of Asian backgrounds, although we don't really have data to know whether changing any of those things really lowers the risk of atypical fractures. But I think the piece of data that's helpful is to know how rapidly that risk drops when you start a medication holiday. So I do medication holidays a little bit sooner, and I might keep people off a little bit longer if they are of Asian background. But we also want to be really sure we're not under-treating that population either, because the risk of an atypical fracture in a woman of Asian descent, while it's higher than other backgrounds, it's still way below their risk of a typical fracture. So we want to make sure we're not under-treating people. But I think it is reasonable to be extra vigilant about how long you have someone on medication and to think about how long you want to keep them off of medication and continue the holiday. And along those lines, the other big piece of information which we are missing is if you've been on treatment, go on a holiday, risk of an atypical fracture falls dramatically. We do not know what happens to that risk if you go back to treatment. We have absolutely no data on that. So we sort of are figuring we're going back to treatment and resetting the clock. We don't know if that risk of atypical fractures resets or if it just goes back to where you were at the end of your previous treatment. We don't know. We're kind of hopeful that it resets everything, including your risk of atypical fractures. But that we don't have any data on yet either.
I see. And so then when we're monitoring DEXA scans when for patients who are on treatment, it sounds like if the bone density increases, that's fantastic. But if it's stable, that also is considered successful therapy. Um,
Yes, that is true. And we have really good data on this from the bisphosphonate trials. And so, especially with oral bisphosphonates, you may not get a significant increase. And part of that is also because in an individual scan, there's 3 to 4 or 4.5% variation in the scan. So you would have to have a pretty substantial gain in bone density to exceed the variability of the test itself. So it's not uncommon for people's bone density to not increase significantly, especially on oral bisphosphonates, but also on other medications as well. And so as long as they're stable, we're good to go. And we have good evidence from the oral bisphosphonate trials where they looked at people in the treatment group whose bone density stayed stable compared to people in the treatment group whose bone density measurably went up. And they both had the same fracture benefit. And when they matched the people in the treatment group, so they took the people whose bone density stays stable and matched them with someone from the placebo group with the same, age and demographics and all of that, when sort of tried to do a pairwise comparison, the people in the placebo group were losing bone. And so if you're stable, you're actually ahead of the game, because if you weren't on treatment, you would be losing bone. And so that's probably why the fracture protection is the same, whether or not the bone density goes up, in addition to the other structural improvements that aren't captured by bone density.
that's interesting that the fracture risk reduction is the same if they're
It's the
stable versus
same.
if it goes up. Okay.
And
And
I
then
think it's helpful to coach patients on that too, or to set their expectations. And, okay, we're starting on this agent. Let's see you back in a year or so and see how your bone density is doing. And as long as it's stable, we're good. So they're expecting that. Everyone likes to see the bone density go up, but if you can kind of set their expectations that stable's good, then when they get bone density next year and it's stable, they're perfectly happy with that.
I see. And then what if it goes down on either bisphosphonate or Prolia? You talked a little bit about checking compliance with Fosamax, maybe bone turnover
Yep.
markers, but what are other things we should be
Yeah,
doing?
bone density should not go down on treatment. And so
Yeah.
if it is going down, something is wrong. And so screening for cause of secondary osteoporosis, and the big one I always screen for bone loss on treatment, is look for myeloma. And that was picked up in clinical trials because clinical trials all had a safety net. So if people were, because it was placebo controlled, so they had a safety net, blinded and placebo controlled, a safety net that if a person lost X amount of bone in a year, they got pulled out of the study because they assumed they would be on the treatment, or on the placebo, and need to get out of the study and get actual treatment. A lot of those people end up having myeloma. And so anytime somebody's losing bone on treatment, I think myeloma is a big thing that you have to screen for, even if the calcium's normal, even if the kidney function's normal. We've picked up people who have developed myeloma, and the sign was continued bone loss despite treatment. So screen for secondary causes. If they're on an anti-resorptive agent, it's really helpful to see what the bone turnover is, especially if they're on an oral agent. If they're on a parenteral agent, bone turnover is going to be low. I still measure it, but just in case something weird is happening. But it'd be really unlikely if they're on a parenteral therapy that their parenteral anti-resorptive therapy, and their bone turnover would not be low. That would be really strange. So then if their bone turnover is low, then it's appropriate to think about switching to an anabolic agent if they're losing bone. If they're on an oral bisphosphonate, they're losing bone, and their bone turnover is not low, then you can just switch to parenteral anti-resorptive. But if their bone turnover is low, then you need to think about switching to the anabolic agents. And we've got, 3 for women and 2 for men. So romosozumab is only FDA approved for women. So if you need an anabolic for men, it's going to be either baloperitide or teriparatide.
I see. So that's a great pearl about checking for multiple myeloma if we see those
Yeah.
T scores come down. And then I don't think I'm going to be prescribing any anabolic therapies, but what are some other indications that you consider anabolic therapies for, other than the one you just mentioned, where if they're not doing well on Prolia?
Yeah, I think we're really evolving our approach to anabolics. And what has happened over the last few years is there's been formal analysis of the post-marketing surveillance for teriparatide and abaloparatide, and showing that there was no increased risk of osteosarcoma or any bone cancer on those agents. And so the black box for those agents, which included recommendation for 2 years of use in a person's lifetime, that was removed in 2020. So now we could potentially use them more than 2 years or more than 1 2-year course. And so that has kind of expanded our ability to use anabolic agents. And then, of course, about 5 years ago, romosozumab was FDA approved for women. So we've got an additional anabolic agent for women. And also concurrent with those changes, we're getting more evidence that starting with an anabolic agent reduces fracture risk more effectively than if you start with an anti-resorptive and go to an anabolic later. And so that's been kind of disruptive because those anabolic agents are very expensive. They're injectable only. And so it's a real battle to get them, period, let alone in a person who's never been on any other treatment. But the gains in bone density on an anabolic agent tend to be much larger if you start with that agent than if you use it later after they've been on an anti-resorptive. We've known that, but the question was, well, does that really mean anything in terms of fracture protection? And now we've got several studies that are suggesting, yes, it does. And so starting with an anabolic is likely to be more effective than if people get an anabolic later. So now we're getting more interested in starting with anabolic therapy, especially in high-risk people, especially people who have really low bone density, and setting them up with a higher bone density for the long term. But it is difficult to get insurance coverage for an anabolic agent first because they are so expensive. And I think Romo has also changed the landscape because it's much easier logistically for people to come in once a month and get their shots and do once a month for a year, as opposed to 2 years of self-daily injections. So I think that has changed the landscape too. I think people are much more accepting of Romo than they would be of a PTH agent, just because the route of administration is much simpler for them and much shorter. It's just a year. So mostly we use them in people who are failing anti-resorptives or in people who are starting out with really quite low bone density. They may be particularly benefiting from starting with anabolics.
And who would you define as having those numbers low enough to consider an anabolic first?
I think anybody below -3 for sure. And you could argue even, anybody in the osteoporosis range, but I think certainly anybody below -3 because these agents, PTH agent or Romo, will increase bone density of the spine about 10 to 12%. And that's about a full point in the T-score. So if somebody's starting out with -3 and they get 10 or 12%, they could be at -2, and you should be able to maintain that then. And so basically you have cured them of osteoporosis, which is a very attractive option for the patients and for us as well, and really could result in very much lower fracture risk over their entire lifetime. So I think anybody below -3, but even anyone in the osteoporosis range really could be considered for anabolic now that we have much more anabolic available to us, and we're accumulating evidence that starting with the anabolic may be better in terms of long-term fracture risk.
I see. So in that case, who do you recommend that we be referring to endocrine to consider an anabolic first, other than those with less than -3 or history of, multiple fractures?
Yeah, so I think those higher risk people, so less than -3, people who've had multiple fragility fractures, people who've had kind of the big boy fractures like vertebral or hip fractures, I think those folks could very much benefit from anabolic therapy. And I think also if people are open to it, so some people are like, I just really can't do the injectable things. And, and the reality is medications, especially like zoledronic acid and denosumab, are extremely effective. And they are much easier to do. A once per year infusion or an every 6-month injection is very, very easy. And so for older folks who don't have quite the mobility and folks who are a little bit more difficult to do the personal injections or get into the clinic every month, those are tremendous options. And I wouldn't want to discourage anybody from using those because they are extremely effective agents.
Okay, yeah. So it sounds like we should be bringing up this conversation probably to a lot more people in terms of starting them on something that's not Fosamax really for improved benefit.
Yep, I think it is. And in terms of the anabolics, it's also an issue because of the insurance coverage. And so it's also frustrating if the person's like all excited about wanting an anabolic and, goes through the endocrine referral process and gets into the clinic and then we can't get it because the
Yeah.
insurance will cover it. So I think it's really something to be thinking about in the very high risk person who is able to implement those drugs.
Got it. Well, thank you so much for sharing your insights and for kind of discussing all the nuances of osteoporosis care. Are there any kind of key takeaways that you'd like to leave us with?
I think probably the screening is very important because I think that gets missed, and we need to get it on people's radar the same way we have glucose and cholesterol and blood pressure and all of those. It should just be part of our standard screening. Also, I want people to always remember all the nutrition and lifestyle implementations and the calcium, the vitamin D, combination exercise programs, weight bearing, balance training, and resistance training. All of those are very effective at helping prevent falls and improving bone density. So we'll make sure everybody gets those. And then in the appropriate person, use medications as well, because those will even further reduce fracture risk.
All right, I know asking patients about to do weight-bearing exercises, balance exercises is such an important component of osteoporosis management. Are there specific resources that you give to patients to work on these exercises?
There are some really great online options which people can use at home, including the Bone Health and Osteoporosis Foundation. The NIH has some great sites, and there's a great site from the Royal College of Osteoporosis in the UK that has some very specific guidance and specific exercises. So I give all of those to patients. And there's also a really great program developed at UCSF with upper body training that has been shown to reduce that forward curvature, that kyphosis. And that's available online, so you can watch it online and do the class along with the women participating in the class. So all of those are great resources to help patients develop an exercise program at home. And we want weight-bearing activity, resistance and weight training, and balance. Those are the three components of a good program to reduce falls and prevent fractures.
Great, thank you.